Hi, my name is Brittany Seal, and this is my Nursing 665 Pocket Journal Guide. So I just continued my journal in the same notebook that I used for 664. So to start off, I started with GI disorders, and I started discussing pain and what the location of pain could mean. So for a right upper quadrant, cholecystitis, lithiasis, or duodenal ulcer, the lower upper quadrant, pancreatitis, the right lower quadrant, appendicitis, and the left lower quadrant, diverticulitis. After this, I kind of jotted down some of the major GI disorders seen in practice. So appendicitis and abdominal aortic aneurysm, cholelithiasis, cholecystitis, diverticulitis, pancreatitis, ulcerative colitis, Crohn's disease, peptic ulcer. So I kind of just went in the diagnosis, the symptoms, and the treatment for each of these. I also finished the GI off with hepatitis. So I thought that it was important, especially in women's health, to discuss hepatitis. So for hepatitis, it's hepatitis A is found in stool and blood. So signs and symptoms is abdominal pain, nausea, vomiting, diarrhea, jaundice, pale stools, dark urine. This is common if you're traveling outside of the country. And I thought it was important to jot down what the test results would mean. So like the anti-HIV IgG would be immunity. The IgM would be positive, means they're infected. You can prevent with good hygiene, telling them not to drink out of the faucets if they're traveling. You only use water bottles, vaccinate, and clean water and food. So hepatitis B, it's found in blood, semen, or other body fluids. So with an antigen, you can see an acute infection. And then for an antibody, you can see that they're immune. And then for hepatitis C, it's also found in blood, semen, or other body fluids. So an anti-HCV antibody, if that's positive, it would mean acute illness. And you would treat these with antivirals. So following this, I went into my benign gyn disorders. So I started off with endometriosis, which is a disorder in which tissue or the endometrium grow outside the uterus, ovaries, fallopian tubes, peritoneum, bladder, or intestines. I thought that it was important to note the symptoms. So onset of pain precedes menses, common in ages between 30s and 40s. Family history is usually a risk. And if you have family history, you have a first degree relative, then you have a 10 times greater chance of developing this. And it is staged by the location, death, and appearance. So staging with this, stage 1 is minimal disease, isolated implants, and no significant adhesions. Stage 2 is mild, superficial implants. Stage 3 is moderate, multiple implants. And that's when it starts getting deep invasion and positive adhesions. And stage 4 is severe, multiple superficial and deep implant, and with dense adhesions. So you want to treat with lifestyle, diet, exercise, depression as needed. Meds, you can use NSAIDs, ovarian suppression, gonadotropin agonists, because they block the sex hormone, estrogen, and progesterone. You can use progesterone, Lupron, and you can get that IMQ 3 to 6 months. You can treat with progestins, aromatase inhibitors. Following this, I went into ovarian cysts. I talked about all the different ovarian cysts, the signs and symptoms of these cysts, and the diagnosis and management of them. Following this, I went into uterine fibroids, which are non-cancerous growths in the uterus that develop commonly in childbearing years. Risk factors is family history, obesity, and early puberty. The signs and symptoms is heavy prolonged bleeding, pelvic pain, bladder and bowel signs and symptoms, uterine enlargement, abdominal mass, irregular contour, and mobile. So you diagnose with a pelvic exam, ultrasound, MRI, HSG, or hysteroscopy. I've seen these a ton in my clinical practice, and I've seen a bunch of hysteroscopies for it too. So you treat with COCPs, progesterone-only pills, gonadotropin agonists, Listida, NSAIDs, iron, or you can have surgery like a myomectomy or a hyster. So following this, I went into the head, ears, eyes, nose, and throats. And I also, just like the GI, discussed some of the common things that you would see. So I talked about conjunctivitis, glaucoma, cataracts, macular degeneration, retinal detachment, otitis media, otitis externa, pharyngitis, bacterial and viral, sinusitis, all that stuff. And I just kind of went in the diagnosis and treatment of all of these. I guess one of the most common pathways to follow in here would be the rhinosinusitis. If it was bacterial, you would treat with augmentin or amoxicillin or doxycycline for 5 to 7 days. And for viral, you would only treat for the signs and symptoms. For allergic rhinitis, it is very common. You see inflammation of inside the nose caused by an allergen. I even see this in my women's health clinical a ton. People have allergies all year round and come in for a GYN problem and complain of this. So you would see sneezing, runny nose. The main things is the cobblestoning and swollen turbinates. And then you can treat with antihistamines, decongestants, steroids, bronchodilators. Following this, I went into menopause and vulvovaginal atrophy. So I think it was important to note the atrophic vaginitis, thinning, drying, and inflammation of the vaginal walls that occurs with decreased estrogen. You can see scarce pubic hair, diminished elasticity, and turgor of vulvar skin, decrease in choroidal moisture, and fusion of the labia minora. So you would treat with a vaginal cream or ring or suppository. You can use Premarin cream, estrace, E-string vaginal ring, estrogen receptor modulators, DHEA suppositories, which is good if you can't take any estrogen. If estrogen is completely contradicted, you can also use over-the-counter lubricants like KY jelly, vaginal moisturizers, Vaseline, Aquaphor for external use, mild soap, warm soaks with baking soda. And then I kind of just talked about perimenopause and menopause and the diagnostics you would see with menopause. You would want to, it would probably be a FSH greater than 30 or estradiol less than 30. And for these individuals, you would want to look at bone density, pelvic exam. You would do a PAP for guidelines and also a TSH to rule out. Following this, I went into GYN-ONC. So I just kind of discussed ovarian cancer, endometrial cancer, cervical cancer, vaginal and vulvar cancer. Now, I have seen a majority of my patients with cancer in clinical, it's ended up being endometrial cancer, and that is a cancer that begins in the uterus. So abnormal uterine bleeding is the number one symptom. You'd want to diagnose with endometrial biopsies. And then I just kind of discussed some of the risk factors and treatment options for this. You could do radiation, Paxlovid, carboplatin as the first line, chemo for advanced stages. And that's about that. I discussed infertility a little bit. I really just discussed the definition of infertility and what could interfere with infertility for men and women. It's important for women for fertility to, one, desire an infant, vaginal capability, patent fallopian tubes, normal ovulation and luteal phase, uterus capable of implantation, adequate hormone levels, normal immunology, and nutrition. Following this, I went to vulvovaginal disorders, and I think that the most important and commonly seen ones is the lichen sclerosus. So with lichens, it can occur at any age, but lichen sclerosus is benign, chronic, progressive, inflammatory disease. This is what I've seen the most in my clinical. Symptoms is pruritus, irritation, vulvar and perianal discomfort, pain with sex and dysuria. You want to educate on hygiene, avoid scratching, increased risk of malignancy. So you want to teach them to do self-exams and signs and symptoms of this. And then you can treat with topical corticosteroids like clobetasol. And then you can treat secondary infections if needed as well. All right, and then to end it off, I discussed breast cancer as well. Breast cancer forms in the cells of the breast, can occur in both men and women. So risk factors: greater than the age of 50, BRCA1 and 2 gene mutations, menses before the age of 12, late or no pregnancy, menopause after 55, not being active. For here, I thought it was really important to mention screening. So for BRCA1 and 2, you want to start MRI annually at the age of 25. After that, you will want to do an annual mammo at 30 and ovarian cancer screen at 30. And then that's it. After this, I just talked about osteoporosis and everything else we discussed in the course, but I thought that those were the main ones to discuss during this. Thank you.